Good evening. So I am Professor Diana Eccles. I'm Dean of the Faculty of Medicine and Professor of Cancer Genetics here at the University of Southampton. It gives me enormous pleasure to welcome you all to this year's Wade Lecture, which I'm delighted to say we're holding as a hybrid event. Tonight, we're welcoming staff, students, alumni, and supporters to the event. We are here in person in the Centenary Building with our studio audience, but we're joined online by over 300 guests from around the world. The Wade Lecture was established in 1970 following a philanthropic gift from the Wade Foundation, which was set up by Mr. E. J. Wade of Dimplex. So an engineering tang there. Housekeeping. Before we begin, a bit of housekeeping for those in the room. There are no fire drills planned, so if the alarm goes, we will need to evacuate and head to the muster point, which is by the interchange. This is where the buses come. Once we've heard from our speaker this evening, my colleague, Professor Gopal Ramchan, whose research interest is in artificial intelligence, will be hosting the audience Q&A session. Please do start to think about any questions you have. For those joining us online, you can submit questions using the Q&A box, which you can find on your screen. For those in the room, we will ensure that you have a microphone. There'll be roving microphones going around. Before I introduce tonight's speaker, I'd like to share that this year's Wade Lecture and its focus on the future of healthcare innovation comes at a particularly relevant time for the university. In the spring, we will be publicly launching our campaign for the Institute of Medical Innovation, the IMI. The IMI will be the first of its kind in the UK, and it will equip us for the future of science. It will bring together Southampton's experts in medicine, engineering, and computer science, plus other disciplines, to work together under one roof in co-designed laboratories. The new building will allow leading experts from across disciplines to work together using state-of-the-art equipment, generating and analysing rich data repositories, and developing and applying fast-moving technologies to deliver therapeutic advances for the benefit of patients. The IMI will be intentionally located alongside the University Hospital Southampton and our other medical research institutes, including the Centre for Cancer Immunology, allowing us unique access to clinicians, surgeons, patients, tissue samples, and many shared resources. This is a £100 million project. The university will be funding £50 million, and we'll be raising a further £50 million in philanthropy to make this life-changing building a reality. We look forward to sharing more details with you as we roll out our campaign, and thank many of you here today for your support of our research, innovation and innovation. Innovation and AI are also the theme of tonight. So on to tonight's speaker. I'm delighted to welcome Professor Ian Abbs to Southampton. Professor Abbs became the Chief Executive Officer of Guy's and St Thomas's NHS Foundation Trust in July 2019. He leads the largest NHS trust in the English healthcare system, with a turnover of 2.9 billion, 23,600 members of staff, and a 5-hospital campus, or 5 hospital campuses. Ian has played a key role in the development of the Trust's life science partnerships and has been responsible for many aspects of the Trust's digital transformation and innovation agenda. This evening's lecture will explore how innovation and transformation beyond traditional staffing and funding are vital to creating a sustainable healthcare system. Ian will outline the challenges and offer optimal solutions for the 21st century. Professor Abbs, welcome.
Diana, thank you so much. And firstly, I would like to thank the University of Southampton, the Faculty of Medicine, and particularly Professor Eccles, Dean of the Faculty, for such a kind invitation to talk to you this evening. And I'm honoured to deliver this year's Wade Lecture. And it is interesting that the origin of this annual lecture series, was via effectively an engineering route. And one of the things I will be talking about is the convergence really of medicine and engineering into a necessary future. And really what I'd like to try and do with you over the next 30 minutes is reflect on the state of healthcare and on the potential futures that that state determines, and how we are going to need to work, to ensure the delivery of future high quality and importantly equitable healthcare. I believe, and I'll argue this evening, and be very interesting to get your views in the Q&A, that the time for action is now. That we need to act decisively and collaboratively um, to protect the system that is not only important to um, our patients and our public in this country, but is part of the social fabric of this country. Um, these questions that we face are global, certainly in all high GDP countries. And I think we need to find both local collaboratives, but global collaboratives that are going to look to the future sustainability discussion. Importantly, I will argue that it is only through innovation, but importantly, the adoption of innovation equitably, that is a solution to that sustainability future. So thank you again, Dana and colleagues, for the invitation. So at one level, is there a problem? So this graph shows that actually over the last 2 centuries, there's been a roughly, this shows data for women, there's roughly been a 1-year improvement in life expectancy for every 4 historical years. That's pretty impressive. And all predictions on the right of that slide of the absolute limit of life expectancy have all been wrong. So actually, life expectancy has generally improved. There are many reasons for that, some of which are about the healthcare system and its delivery, some of which are social. And 1948, the establishment of something that we, I think, all hold dearly, the National Health Service, so embedded in the social fabric of this country that it formed a majority portion of the opening of the Olympics in 2012. We've had, and certainly the founding fathers and mothers of the health service believed that investment in healthcare would ultimately lead to a sustainable, healthy population. But the investments in healthcare have been steadily growing since 1948 in all high GDP countries. And this graph shows the relative proportions of GDP expenditure. And in the US, it's coming up to 18 to 20% of GDP. And so at one level, one would expect almost linear increases in annual healthcare funding in high GDP countries must be associated with improving healthcare, at least measured by life expectancy. But that's not true. So what this rather complex graph shows, and perhaps if you just focus at the top right of the graph, is that despite, in some cases, log increases in per capita spend on healthcare, those life expectancy, at least one measure of healthcare effectiveness, are flattening off. And more granular data, certainly in some sub-states of the US, has actually shown that despite still maintained high financial inputs into healthcare, that mortality is actually life expectancy is falling. And so we've probably reached in some countries the top of the expectation curve that money alone will fundamentally change the outcomes of healthcare. So the other factor of supply, one factor being resource financial input, the other very important factor of supply is workforce. This is a very frightening slide because in the US, the health and care sector is now consuming more humans than work in US manufacturing or retail. And those curves crossed somewhere between 2005 and 2008. And in this country, we are consuming over 1 million people in direct healthcare delivery. We probably consume about another 750,000 in social care. And of course, third sector um, resource utilization in people. We've got probably upwards of 2.5 million people involved in the health and care sector, often from a tax base of about 17.5 million. What's going to happen next? So these are US data, and it is predicting that in the US, um, uh, health and social care is going to require the most significant increase in human factor in workforce supply than any other industrial segment. So we're probably at the top of the financial resource curve. I'd argue we're probably at the top of the sustainability of the human resource curve. And for all of those inputs at the top of the curves, are the outcomes for the patients that we serve great? So this map is from the CMO report 2021, which looks at the outcomes for coronary artery disease in England, and red is bad. And so there is deeply inequitable distribution of outcomes across England, with particularly poor outcomes in communities, particularly with higher levels of social deprivation, and particularly coastal and northern communities. So despite in this country, 208 billion pounds of expenditure in the health system and roughly 2.5 million people involved in health and social care, we are not currently able to deliver equitably to our patients who deserve it the healthcare that they need. And how is that associated with satisfaction? In 2012, the opening ceremony of the Olympics focused on the NHS as a main societal good and benefit of this country. These graphs show public satisfaction with the NHS between 1983 and 2023. And whereas pre-pandemic, and clearly the pandemic has had an influence, but pre-pandemic, something like 60 to 70% of the public that we serve were highly satisfied or pretty satisfied with the healthcare delivery system in this country. And roughly 20% were dissatisfied. However, those numbers have now inverted. Up to 2023, and the social attitude survey most recently actually confirmed this again. So this is not just an immediate hangover from the pandemic. But now we're looking at dissatisfaction with the NHS somewhere between 50 and 55%, and satisfaction falling into the 20s. So again, despite those factors of supply, which are probably at the top of the curve, not only do we have poorer outcomes than we would wish, and you could take any measure of outcome other than coronary artery disease, and you see similar discrepancies. But also, very importantly, the satisfaction with care from the general public, our taxpayers, and the people to whom we are responsible and accountable, is falling. Does that matter? So these data, I think, are key, and I'll show you on the next slide the source for this. So this looks at uh, satisfaction with healthcare in a number of countries. So this is from Copenhagen WHO office. And it looks at the spread between those who are satisfied, who are often those in good health, and the lower levels of satisfaction, often those people being in poor health. And what this important paper shows, and I would strongly recommend colleagues sourcing this paper, and certainly for our students, because what this paper also shows is that strongly associated, whether it's correlated, but strongly associated with poorer levels of healthcare satisfaction are a tendency to be less involved in democratic processes, to be less trustful of the structures of democratic societies. And whereas back in the sort of 1930s and beyond, there was a tendency within groups there to vote towards the left, there is a tendency within these groups to vote towards the right and the hard right. So I think we're starting to see, not just in this country with levels of dissatisfaction, that if we do not do something to fundamentally change the equations which no longer balance, equations which have been balanced since 1948, certainly in the post-war period in high GDP countries, those equations are no longer sustainable. But if we don't do something about it, not only will we see outcomes and satisfaction with healthcare degenerate, I would strongly argue that we will see the fabric of society fraying. So my first, and I hope persuasive point to this audience this evening is that this matters beyond the very nature of healthcare. It matters in about the societal compact. Because fundamentally, supply side, particularly associated with financial input and human resource input, no longer balances demand. And all of us, I'm sure both those in the audience here and those online, would recognize in many of our own experiences and those of our families that currently we are not keeping up. We are on a scree slope of increasing gradient. And so I strongly believe, and I'm now going to try and argue to you, that we have to reimagine, we have to creatively reimagine a health system enabled by technological innovation and particularly by the accelerated use of artificial intelligence. And that's the gradient of that scree slope. It is getting steeper. And on the left of this slide shows something that we all experience, I suspect, in our professional lives, certainly those of us that are involved with healthcare delivery, is that it is going to get steeper because healthcare inflation always outdistances background inflation. So we're running on a scree slope. And I'd argue that our colleagues, the brilliant people that work in the NHS, we can't get them to run any faster. And I'm sure you've also seen in your experiences that the sort of discretionary effort that's often been associated with the sustainability of healthcare is no longer at a level that is going to make a significant difference to that scree slope. But there are coming one of the brilliant things, because despite what I have painted so far, I am an optimist. And I am optimistic that if we do something, if we come together as a social movement, if we come together to really accelerate some of the opportunities of what is the fourth industrial revolution, um, if we take some of those opportunities, we have a chance of rebalancing the equations. But I think they only rebalance if we adopt at scale and at pace. And I'll come on to some of the options. But there are options. And the panel to the right of that slide looks across the whole spectrum of healthcare delivery. And I'll come on to a minute. This is not just about clinical direct delivery technology, including artificial intelligence, but the entire spectrum of the healthcare delivery system is tractable to new technologies, including AI. And we also, not only do we have this moment in the fourth industrial revolution of now being given the sort of the tools that will make a difference, and it's only obviously in the last few years that we started to see some of the later developments in artificial intelligence, including large language models and generative AI. But the government policy and NHS policy is to look to the enablement of that. So I was very fortunate, I think I was fortunate, to be asked to co-chair the working group on innovation adoption and spread for government for the OLS with Dominic Dodd, the chair at UCL Partners. We had a fantastic working group from entrepreneurs at one side of the spectrum and the chair of GSK, Jonathan Simons, at the other, really trying to dig into this question because we have no lack of creativity in this country, but we do have barriers to the adoption of products from that creativity and importantly, their spread. And so now I'm going to focus from the problem into some of the solutions where, again, I think we need to act collaboratively. So I would certainly, as well as that paper on social attitudes, I would strongly recommend perhaps reading an AI summary of the life sciences sector plan and of the health 10-year plan. And there is a read across between the two. We do have some deployment choices, and it'd be interesting to understand from you and perhaps in questions from you on where you feel effort should be directed. But there are deployment choices currently in those technology. But before doing that, and certainly those engineers in the room, I'd be interested in your views, is it has to be true that digitizing or putting layers of technology into a fundamentally bad process is going to give you a fundamentally bad process at the outset. We are very poor at rethinking, reimagining the delivery models of healthcare. So I am obsessed with the concept of outpatients. So certainly at Guy's and St Thomas's, we see 35,000 people a week. It's the population of a small town in our outpatient clinics, where our patients come up, we make them wait. in space that occupies about 12.5% of our total uh, buildings, their waiting spaces, to have an encounter with a clinician, often without any pre-loading of information about the patient, with better medical records now, the electronic records than we had, but with often a relatively low value encounter for patients. What would we do if we redesigned the system to start with and we went to 3,500 patients a week rather than 35,000? So I'm just making it clear, particularly for students and only graduates, I would certainly start challenging all of us on, is the process that we have really necessary? But assuming we are willing to redesign the process, then there are many areas, and here's just some examples provided by my close colleague, who is actually a professor of healthcare engineering, Seb Orsolan at KCL. And this convergence of healthcare and engineering is a fantastic opportunity, as it is in the convergence of genomics with engineering. But we're already seeing opportunities for direct improvement of clinical care. So predictability, for example, of an intervention, improving a patient's outcomes. So clinical care, absolutely. Certainly for improving clinical efficiency. And so many of you will be familiar now with the AI technology, which is available for reading CT head scans to predict the presence of an infarct versus a bleed and speeding time to important outcomes for patients, including thrombectomy. So we've already seen that in clinical deployment. Trying to understand the outcomes of care for the cost of care. Um, uh, uh, Diana and I were discussing, for example, at the moment, how broadly spread are the technologies for looking at genomic sequencing of tumors to predict effective chemotherapy versus if any histopathologists are in the room, I apologize in advance, looking down the microscope at a picture. Are we willing to challenge ourselves on substitutive types of technologies? So value-based healthcare for clinical audit and for operational efficiency. I think this is a very interesting um, opportunity. In many ways, the processes of healthcare, and again, I apologize if this sounds a little bit reductive, but the processes of healthcare are often logistics. It's enabling the patient to be in the right place for them with the right clinical information that allows the minimum clinical resource to deliver the outcome a patient wants. That's a very simplistic value chain analysis of healthcare. But a lot of that is a logistics business. There are many industries that have optimized their logistics workflows. We haven't done that in healthcare. What could we do with AI? We did an analysis, and this is embarrassing to admit before this audience, but we did an analysis of um, uh, using actually fairly simple analytics to determine that some of our patients in our system in Southeast London have 88 outpatient appointments a year because they're tending to be bounced around lots of different parts of the system. And there must be a way to improve that. So I think one of the very important areas is to go after as much about the clinical AI, but about logistics AI. At the moment, 80% of deployed artificial intelligence is in radiology. That's really been the main focus of deployment so far, rather than in other areas of clinical practice or in areas of operations management. I think you have an MBA program. I think it'd be very interesting to see what the MBA students think of the logistics of our healthcare system. Um, I won't dwell on this slide, but one of the observations that came out from, and I'm very happy to share the slides down if that's useful for colleagues. One of the things that came out is that for the adoption of the technologies that already exist, we have a very high friction system. Um, so I know there'll be people in this room or online who have tried to get stuff done. I'm very interested in the Institute of Innovation you're going to be developing. Because again, we have no lack of creativity, we have no lack of invention, we have no lack of innovation, but our ability to deploy and spread with effect is poor in this country. And whether it is at early stage, mid stage, or actually developing more general spread, we need to do some things around that. And one of the recommendations or sets of recommendations in the life sciences sector plan are here. So I think we have to be optimistic and positive and believe that the government is going to do what it says it's going to do in the life sciences sector plan. So, for example, really to the benefit of our patients, slashing the time it gets currently to be in a clinical trial. So our clinical trial setup, recruitment, and delivery is far too slow, and we need to use probably data tools to do things like cohort analysis, patient recruitment, patient monitoring. You will all have seen it's beyond an existential threat that this country currently faces from the exit of large pharma. The fact that MSD, 110 scientists have left the crick and are on their way either to the States or to no job on the decision that that company took to leave the UK and go to the States. We have to reverse that. It's not all about trial recruitment. It has to do with things like drug pricing, and it has to do with things like the tariff uh, issues with the US. So there are complex reasons, but we have to make this a low friction, pharma and technology friendly environment to bring these technologies, particularly, but also pharma products to our patients for patient benefit. Then there has been, there will be more investment in R&D. One of the things that I think will be very important is that second bullet point, which is the access to scale up capital. And the government's spoken for some time about the Mansion House Accord and about the release of capital from pension funds, because certainly we need to try and introduce not only capital for development, but capital for investment in companies. I don't know if anyone in the audience has a startup. Um, uh, and if you're thinking of a startup, please do. But if you're thinking on basing the revenue plan of that startup on NHS funding, the way we are at the moment is you will not get VC money in this country. So we've got to find a way of freeing up financial flows, both from the NHS as a customer for technologies, but also from things like the financial markets and particularly the pension funds. And there's it is important. The third point is that we need to make a radical difference to patient access. And ambition should be that all patients should be in some type of evaluative study, whether it's a clinical trial or whether it's a study of technology or a study of a new process, because the outcomes, we all know that there is good evidence for patients involved in clinical trials having better outcomes. And I think it is our collective job, this community, our community, to hold the government to account on the delivery of the life sciences sector plan for the benefit of the patients we serve and the staff who serve them. So I would definitely, and I'm very happy to share these slides, but I also definitely recommend a look at the life sciences sector plan. What I'm hopeful at the moment, we have a relatively high bar for the adoption of artificial intelligence. And one of again, we may come on to discussion in a minute or so on risk appetite. The, the clinical systems, not only in this country, but many countries, um, have a particular risk appetite, and I would argue fear, in fact, of doing something, particularly the adoption of technology. And there are many examples of technology, probably not yet deployed as widely as it could be. I'll be a little bit controversial. There's a dermatologist in the room. Skin analytics, for example, which is, has high level evidence for a type 2 regulated medical device. Actually, its adoption in this country is pretty low. And there are issues about risk of adoption. On the other hand, there are 600,000 people on the dermatology waiting list. And Gopal and I were at a meeting the other day, actually, where a dermatologist was discussing this. There are 600,000 people on the dermatology waiting list, 5,000 of whom have an undiagnosed melanoma. And so I think we need to become more mature in our discussion of risk appetite and risk avoidance, and actually to become much more conversant with the risks of inaction, because we tend to overweight action as being high risk and the status quo as low risk. I'd argue it's the other way around. But it's good. So Professor Alistair Dennison from Birmingham is going to chair a working group with Lawrence Talon, who's currently Chief Executive of MHRA, about the regulatory framework for artificial intelligence. And I think this is going to be hopefully a rapid assessment process. And then, of course, what Southampton has is Gopal. And so I'm very honored as well, Gopal, to sit on the Responsible AI Council for Healthcare. We had a fantastic AI Champions, I'm sure that Gopal will talk about it in a second, Champions meeting at the Royal Society of Engineering a couple of weeks ago. And there's huge energy, there's huge enthusiasm, particularly amongst some of our earlier colleagues, some of our early career colleagues, for these types of technologies. But we do have to find that roadmap at the center of the slide for the ethical and equitable um, deployment. I would certainly argue for those checks and balances in deployment. But the work that Gopal and colleagues at Southampton are leading is one of the steps, I think, to that ethical deployment. And so, in conclusion, I'd be very interested in the audience's questions and advice. I strongly believe that we are at a point where the historically balanced equations of healthcare supply and demand no longer are true, they are fracturing, that we have no option on money or people to rebalance those equations. Therefore, we have to fundamentally rethink the operating model and to enable delivery of that model with the technologies of the fourth industrial revolution. That if we don't do that, then further erosion of public trust and outcomes of a healthcare system that we hold dear in this country will further erode, and that we will start to see the fabric of society fraying. So I would therefore argue that if not now, when do we accelerate adoption? And if anywhere in the world, why not here? But it will need us all working as a community to deploy these types of technologies for, I think, our ultimate goal, which is to save the system that we love so much for the future generations to come. So thank you very much.
Thank you, Ian. That was an amazing talk, as um, and I have plenty of questions. But really grateful to have you here, and really grateful to have you involved on Responsible AI UK's Health and Care Working Group. Um, so You've heard Ian. I'll just now follow up with a short overview, and thanks to the viewers online for their questions. You'll soon see a pop-up on the screen for any questions for Ian. So please use that to drop in your questions, and we'll start with the Q&A in a second. But before we go into the Q&A, I'll just give you an idea of what we are doing at Southampton and across Responsible AI UK. And thanks, Ian, for the very kind introduction to RAI. So I'm Gopal Ramcha, I'm the CEO of Responsible AI UK. I've been at Southampton for maybe 25 years now. I started as a PhD student here and now running this large program. And previously, I ran a program called the UKRI Trustworthy Autonomous Systems Hub. Southampton is a major center for AI. It is playing a key role in the UK in shaping AI regulation, the technologies underlying AI, AI sustainability, AI engineering, and the applications of AI to key sectors such as the health and care sector and defense and security as well. I don't know if you know this, but Southampton holds currently about £56 million worth of AI-related grants across a number of faculties: engineering, medicine, social sciences, geography, etc., etc. So a number of grants, including grants in the School of Medicine or Faculty of Medicine. So Professor Saranis has over £1 million of grants in the Wessex SD, in the work that she's doing across genomics and AI, and supported by other grants across the university and in investments in new academic positions in the Faculty of Medicine. The Faculty of Engineering and Physical Sciences has grown, actually investing over a few £1 million into new roles to grow its capabilities in AI. But we also receive a lot of funding from our national funder, so UK Research and Innovation, UKRI. Responsible AI UK is their flagship AI investment. It is a £33 million program. And it's not just a research program. It does invest in a lot in research, but also in translating that research into real world applications. At Southampton, for example, RAI UK funds the Accelerator program, which is led by Future Worlds, our own local incubator, and UCL Center for Digital Innovation. So we're working with researchers, AI researchers across the UK to create new startups, some in healthcare. And we're also funding a number of fundamental research projects, the Keystone projects we call them, a number of skills projects across the UK, and working very closely with DCIT and a number of other government departments to translate that into white papers and policy advice. And the picture you have of Professor Prokar Dasgupta, who leads our health and care working group. So we've invested in creating a health and care working group that looks to connect the ecosystem across the UK and internationally to look at translating some of the research that is being done into real world solutions, but also to learn from practitioners who are using AI on the ground. So RAI's Health and Care Working Group is made up now of, I think, over 80 AI champions, we call them. It's an amazing network connecting all the NHS trusts in the UK, plus practitioners across the world as well. At Southampton, we also host a number of key investments, such as the Sustainable AI Centre for Doctoral Training. That's £15 million. And recently, we were awarded the Wessex ARC, led by, I think, Cathy Bowen and Professor Michael Boniface from ECS, and that's £15 million. We also have the Turing AI Fellows, Sebastian Stein, and a number of investments in geospatial AI as well. So lots of funding comes through not just because Southampton is a great university and has great researchers, but also because I think we have a unique mix of world-leading expertise in a number of domains. So lots of collaborations going on across medicine, electronics, computer science, engineering, geography. It's a really great place to be, and that's why I've been here for the last 25 years. I think we need to build on these strengths. And platforms like RAI, on investments in various faculties, on the ARC that's been set up, you would really go out and build on those to further our early career researchers' careers and win some of the grants that will soon come out from UKRI. For example, now DCIT has awarded a higher budget to UKRI, and we should see greater investments in AI for science. So I encourage you all, researchers in the room, to think about new potential bids for calls that will come out next year. Do not wait for the calls to come out. Start writing your thoughts down and get together to co-create some interesting research projects. All right, so that was me and talking about AI at Southampton. I'll now take questions from the floor. I have a few of my own if I get a chance to ask them to Ian. But Ian, please come over and let's have a chat. Maybe we can put these chairs here. And Sarah will monitor the Q&A on Slido online. Okay, we have one question. Let's start with you. If you can please introduce yourself and
Thank you very much. Such an interesting talk. I'm Karen Buttigieg from the UK Health Security Agency and an alumna of Southampton. What sort of measurable outcomes do you think a reimagined healthcare system, as you have challenged us, would look like? So should we be trying to seeing more patients and churning them through faster, or having more sort of high quality clinical encounters, or making life easier for the clinicians and healthcare workers who are on their knees, or something else?
So I think I would start with a really reflective examination of the outputs, outcomes of the current system. I mean, one of the things I would say is I don't believe the NHS is broken. It is bad, but I don't think it's broken. And many brilliant things happen across the NHS every single day. However, I think if you look in aggregate, we have areas where there is certainly outcome and experience room for improvement. So I think I'd start really with quite a transparent examination of that and a transparent discussion of those outcomes with the people that we serve. I think the second thing is many of the processes that we have are hangovers, and I'm sure there are medical historians in the audience. They're hangovers from the Napoleonic model of hospital-based medicine from the sort of middle of the Victorian period. Just while we were talking earlier about particularly the technologies that are available today. So large panel analysis of certain tumor types for chemotherapeutic high precision use, which not only is better for patients in terms of the outcomes, but going to the right drug first is highly likely to be associated with a better value proposition for that particular patient. But if we're going to use large panel genomic analysis, which I strongly believe is an example of executable genomics, then we have to stop looking down the microscope at pictures. I loved doing pathology. I loved it. But actually, it's no longer standard of care. And so, but that's very challenging for a profession. And I have some of my best friends are histopathologists. But actually, we do need to challenge some of those historical models. And I'll just, so I shouldn't extend it too long, but Petri dish, which is the standard of care in the analysis of infection, it's 1860. Blood agar and patents. Now we have technologies to examine the genome of pathogens much more rapidly, 6 hours versus 48 hours. And then there's going to be a question, though, because there is an issue about incumbency. How do we change from something that we've been used to since 1860 to something that is very, very new? The combination of biology and data giving an answer in 6 hours. So I suppose I would, and that's actually being done in collaboration with UKHSA. So I do think we need to think very hard about the outcomes. We need to think about how could we fundamentally rethink the processes and then use technology, as I mentioned earlier, to substitute higher value propositions than lower value propositions. That's probably how I'd start.
Thanks, Ian. Do you have any other questions in the room? 1, 2, 3, 4. So if you can just get all the questions and we'll try and see whether if there are any overlaps, we can address all of them in one go. So, Dhaka, start with here, there, and then
I'm Bakr Bahaj, and I'm an engineer. I'm a professor of sustainable energy, but I do a lot of work in how technology can help people. My question to you is related to barriers. So engineers really wanted to work with the health sector, but there are so many barriers, especially around data, which actually blocks that. And I can tell you an example with a local authority, which is which is social care, where we try to provide a better reliability of delivery of healthcare to people who are, in requiring it through data. And we got to the point that we actually got the information that's required to happen. We build the kit that's needed and so forth. But we could not get access to the data of the patients. And that's really a major barrier. So my suggestion to you, how do you break that barrier to start with? And I think I'm really glad that you came here and talked to us that you are trying to do it. And the second one, could we have an exemplar city like Southampton or like London, where we break all those barriers and do everything we need to do with data?
Can we take two more questions and then we will come back to that. So if you can. So barriers to accessing data. Question on that one.
Keith Godfrey, I'm a clinical academic in medicine. So I'm with you about the need for a revolution in secondary care with molecular and AI and the rest of it. But I've just come this afternoon from the DHSC Equity and Equality Steering Group, and we're not going to solve problems by concentrating on secondary care. Don't we need an AI revolution in public health and in a national food strategy, for example, if we're really going to get a grip on the healthcare impending disaster in this country?
Thank you. Interdependencies with other things, and one more question, or two more questions here, I think. So you can try and keep that in mind, because I'd like to get to the online questions as well, and we have very little time left. So
thank you, Professor. Sorry, I'm Nigel Coopey, alumni, diverse background in the IT sector, most recently with Nokia. I did spend a bit of time at the UK HSA, which provokes my interest in this sort of thing. You asked earlier for a vote between process and patient deployment. Don't worry about the patient deployment. All the conversation has been about the patient deployment, to my mind. Process is so broken. I find all the time in my family great pockets, as you said, of innovative and excellent healthcare. We can't get to them. Okay. I mean, I'll give you just one very small example. 2 days ago, my wife got an appointment sent through to her by a secure app, not the main NHS app, so another one we had to register with, to get a letter for an appointment in 10 days' time. A day in the post, she got a letter copied to our GP saying that this appointment would come in a week or two. And whilst we've got it that broken, why are we worrying about how well we intervene when we get to the intervention? Okay, we've got AI-powered racing cars in terms of interventions we can now do, running on process track designed for horses and carts. That's my vote.
Okay, we'll now go to the answers. Thanks.
So the short answer is yes to all of those points. The slightly longer answer on data access. One of the other things I'm doing is getting the London secure data. Doesn't really want a man, but I'm trying to get the London secure data environment up and running and utilised. We had a fantastic 100-strong public panel. Most members of the public think that we are already doing what you've said. It's actually structures within the health and social care system that are more causing more blockade to data transfer than the public expect. The second question, and perhaps I didn't emphasize it, the most important place to deploy new thinking, resources, and I'd argue technology, particularly large data models, is actually in population health. Whatever we think population health means, but we've run, and perhaps I should have said it, certainly Guy's St Thomas has been a community provider since 2009. So I see the health system. I've stopped trying to think about hospitals and communities. But actually, the big return is probably management of, in short terms, one of the big returns is better predictive analytics and management of high risk 10% segment of patients who present to emergency departments who probably consume 30-40% of resources. If you could halve that and offer better, more responsive care, some of which could be, and this is straying onto areas of controversy, if you could do some of that using agentic AI, and there are models starting to offer patients support through agentic, because we certainly don't have enough people to ring someone up every day and ask them about their social and health circumstances. But if you could halve that cost, then you have the sort of headroom to do the things you were saying. And then I completely agree. I mean, and actually the processes do not need as much regulatory approval, but it does require you to take, I think that's why engineering in medicine is so important. And many of these processes are engineering processes, logistics management and inventory management. We need to take the learning from engineering and apply it in health, which is I'm so interested in your Institute of Innovation.
I'll just thanks, Ian. That's a great answer, and I can see you're an AI optimist. I'll build on some of the questions that have just been asked. But you talk about using AI to reduce costs to improve outcomes, but it can also increase costs, right? So there are sort of paradoxes and I'm not sure whether people are aware of this, but if you have higher resolution pathology or high resolution colonoscopies, you can find things that are need more treatment, need treatment, but may not be high risk, and you create more work. You create more work for the entire, so and you overwhelm the system because of the high accuracy of the system. So if you detect things, you think you need to fix it, and therefore, even though they don't need to be fixed, it's an awareness, a measurement of that.
Yeah, so I think that's always been the case as we scale up the fidelity of the whatever analytic technology one's using, from imaging to genomic analysis. And then we've got to have better conversations about relative risk, and we've got to understand through combinations of technologies. So, do we understand at a genomic level the risk profile of a certain lesion that we might have seen perhaps now at higher fidelity on an AI-enabled mammogram? And what do we know against the data sets that we have of progression of breast cancer? But we need to have these very large data sets to enable us to understand the baseline position, but then train the sort of algorithmic technologies then to and actually come back to that so that we iteratively understand.
Excellent. We'll now take some questions from Sarah.
Great. We've had very similar interest online. The question as to whether the clinical AI or the AI should be deployed on the clinical intervention or on the process. So I think we've covered that one already. We've got one question. Could AI one day become a co-clinician, and what would that mean for patient care? How do we protect clinical time for adoption and innovation? And we have a question. The third industrial revolution was digital. NHS has failed to capitalize on solutions digital has offered. What have we learned from this for adoption of AI?
So if I perhaps go in reverse, not enough. We haven't learned enough. Comes back to some of the points that colleagues have made. One of the things that is in the life sciences sector plan, which I think is going through government decision at the moment, is a recommendation on large-scale innovation zones. And when I say large-scale, I mean city clusters, where some of the we can test some of those factors that are currently inhibiting adoption, both for the digital technologies we have, but then those technologies of the future. How do we provide headspace for people to adopt these new technologies? Well, I think the first thing is we should be thinking about, when do people need to start learning about them? I'd argue it's in the undergraduate curriculum. So much as I loved the anatomy of the knee while I was training, I don't think I've ever used it. But actually, I think there is a discussion, and unfortunately, colleges and I think we need to engage colleges and the regulator, GMC, on curriculum content, to start to encourage. I'm sure you do this in Southampton, to start to encourage earlier conversations about essentially beyond digital literacy, but sort of into the sort of AI native. It's beyond the digital native, it's the AI native, so that actually it becomes part of the expected work processes as someone comes into employment. I recognize I'm too old really to, learn the sort of stuff that Gopal's now teaching. But I still appreciate that we should bring that into the workplace early.
Be surprised you can use an AI to do my work these days. I think we're out of time, and sorry, there was one last question, a couple of questions, but hopefully you can take those offline. So we'd like to thank Ian again for an amazing talk, and Diana for the intro earlier. So thank you so much.
Thank you very
And
much.
thanks to the audience.